So my talk is more about, let's say, science and politics. I'm going to focus less on the spatial aspect, and actually mainly due to my agenda being completely overwhelmed with other tasks related to the COVID-19 crisis. And of course, this is not my effort only. It's my team that came into play at very different levels. So together with Philippe Beutels at the University of Antwerp, we're running a team at the two universities on infectious disease modeling. We've grown over the past few years from 4 persons to about 30 persons now, from whom about 15 persons are working on COVID-19 modeling. We don't have an official task as such, except I do actually, but the others in the group don't. So we're putting our effort in to help the government in guiding the exit strategy, and of course now preparing also for a second wave. So the situation in Belgium is that we had a first wave, and we're now in the long tail of that first wave. Different phases in the exit strategy have been implemented. And so I'll guide you through a little bit. So of course, there's a lot of people to thank. We've been interacting with a lot of people also nationally and internationally. I'm not going to go over them, but all credits also to them. And just to give you an idea about the Belgian COVID-19 pandemic, and we had our first case on the 4th of February, but this was actually a repatriated Belgian from Wuhan who tested positive for the novel coronavirus. That person didn't have any offspring in Belgium as such. And for us, it was really at the end of the spring holidays that we had a lot of people returning from their holidays that they spent in northern Italy and also in Austria. And it's likely due to that fact that we had a lot of people coming back from northern Italy especially, that we had quite a severe outbreak as such. Now, according to Piet Maas, who's a colleague at KU Leuven in Belgium, the presence of the virus was already established before spring holidays, but it was really this influx of people that made transmission go forward. We can also do that, well, spatially we can map this, also because we have a lot of Italian second generation and so on migrants. And they're located in the northeast of Belgium, for instance, and they're also there, which is the province I live in. We've seen a lot of cases at a certain point. We haven't been involved in the initial stages of this corona crisis as such, but on the 12th of March, we actually did send a letter to the government, including first predictions on possible peak sizes if nothing would have happened. And that, well, triggered the government to go into an alert phase. So they came up, or they were already casting the message to have some hygienic measures in place. But then more and more, it was encouraged to do telework. And on the 13th of March, there was an announcement of schools and Horeca closing on the 14th of March. And actually the schools closing was not really a recommendation that was made. It was more a political decision because France really made that, well, had that decision before. And the southern part of Belgium is a small country, but we have two parts which are politically sometimes not completely in line, let's put it mildly. And the southern part looked at France, and as it does more regularly, and they said, well, let's close the schools as well. Upon that announcement, we also had Corona parties and so on, so since Horeca was closing. And we did see some effects of that afterwards. On the 18th of March, it was decided to go in a lockdown, and what we call a lockdown light, because people were still allowed to get away from their houses and so on, but only for essential travel or for walking around and so on. But you could not take your car and drive somewhere to then go walking and so on. So, and I think it's fair to say that in this initial stage, there were many logistical issues. It was really a logistical nightmare in the sense that whereas we had a strategic stock of mouth masks that was actually destroyed 1 year before. And that's a bit a crazy situation. You learn that being destroyed. And the other thing which will be very important in this story is the care homes, because we've seen a lot of mortality, a lot of people infected in care homes. And it was actually the result as well, or we believe it's a result of budget cuts over several years already. So I can go on in details, but I won't do that. It's just to give you a picture, an idea of the situation. And at the 1st of April, thanks to a colleague of mine who was interviewed on telly, I was approached by the Prime Minister to be one of the 10 persons in what we call the Gs. Some people call it the BGs, the Belgian Gs. So we have our song, Staying Alive, that we play every meeting. No, but they really asked us to come up with an exit strategy. And of course, as everyone, I think, can realize, it's easier to go into lockdown than to reopen, because of course, everyone wants to reopen sooner than the other. And so there's a lot of political pressure, a lot of lobbying and so on. And we've put forward in our exit strategy. So we went in lockdown on the 18th of March. We saw the impact of the lockdown quite quickly, although our tail is very slow, let's say, and it's a long tail. And we distinguished between 3 phases initially: on the 4th of May, on the 18th of May, on the 8th of June. The 4th of May was really about restarting economy, B2B, business to business, and B2C, which is business to customers like retail and so on. And whereas retail was for us something that could start up at the 18th of May, because it is more risky than business to business starting up again because of different protocols and so on in place. The government decided to push that forward to the 11th of May. And what was also quite annoying at that time, they also came up with this 4 contacts rule. What does that mean? Every family, every household is allowed to meet up with 4 other persons. We've never advised for that rule. We were actually advising against a rule like that, because what of course happens is that this number 4 becomes a kind of the holy grail. Everyone is looking at this number 4. For some, it's an obstacle. For others, it's kind of maximizing what they can do in terms of social contacts. On the 18th of May, schools reopened up, at least partly, and that was also quite a struggle actually to really look at which years in school could open up. And so there was a proposition made from the educational world, and we tried to actually, in the modeling, we tried to take that into account to address this, whether this would be safe to open up or not. And also some of the close contact professions opened up again. Some politicians were really worried about their hairdresser and so on. So also that was a little bit pushed forward. And then on the 8th of June, phase 3 was actually started, and they reversed the logic by saying, well, everything is actually allowed, but a few things are still prohibited. And so now Horeca has opened up, as well as other sectors, and we are very curious what this will mean in terms of a potential resurgence. We still have cases. We're still relatively high compared to our neighboring countries, except for the UK then. And everything went well. All the phases 1A, 1B, and 2, we've been doing a good job, I think. But phase 3 is, of course, still a larger step, I would say, in the scheme of things. And so we're really wondering how this would go. We needed an easy tool to actually look at this reopening. And together with Marius Gilbert, who is a colleague at the University of Université Libre de Bruxelles, we came up with these 2 parameters that we could keep an eye on: the number of new hospitalizations and the number of new hospitalizations as a daily ratio. And what you see on the right-hand side is actually a picture where you see a starting point. Here is the 28th of March, and then you see actually that you see cycles in terms of the numbers, in terms of new hospitalizations, and in terms of this ratio. And this ratio is estimated on a 7-day average of the new hospitalizations. And the focus on new hospitalizations was really there because it's the most stable indicator that is present in Belgium, at least. As in many other countries, I think. The testing strategy has changed dramatically. We had a very narrow test strategy initially, and nowadays anyone who wants to be tested can actually go for a test, which makes it extremely inefficient at the same time. But I think we now, for a population of 11.5 million, we have about the space of 25,000 to 45,000 tests per day. And a lot of people are curious about their status as well. But of course, then the mix-up between PCR testing and antibody testing is not really well understood. So communication has been quite difficult at times. So we have different data sources that we started collecting right away, actually. So the government also has data sources that they collect on number of hospitalization, number of deaths, as well as on confirmed cases. Some other data sources like mobility data and so on have been gathered in a data against corona task force. And from our side, we've been collecting data in what we call the large corona study. I will come back to that. And then social contact data is an initiative that we started and which actually emerged from the whole polymoth contact data collection, and which we now have transferred into a friendly tool for people to use, to exploit. It's all data about pre-pandemic times, but at the same time, you can play with these data to mimic certain intervention strategies. I'll come back to that in just a moment. We're also collecting new data, which are the comics data. It's social contact data during lockdown, and gradually every 2 weeks, basically, we're collecting these data. Initially, this was limited to UK, to Belgium, and to the Netherlands, and now it has been expanded to other settings as well. Also, the methodology has been shared. So also in Canada, for instance, Marc Brisson is using this, and other people have been using this. And now we're also expanding to 15 more countries in Europe, as well as other countries are taking over some of those data collections. And we will make these data available as soon as possible. And then we've also been collecting serological data, and I will talk a little bit more about that as well. Just to say, I have too many slides. I will not cover all of them, but I want to give you an idea of the work we've done, and I'm happy to go into more detail if there are questions afterwards. So the large corona study is really a study that we developed at the University of Antwerp in collaboration with other universities. And what we've done there is we started collecting information about people's behavior. And so it's a weekly online survey. It's focused on the general public, but of course, with self-reporting surveys, we know that there is a bias in there. To date, we have 12 survey rounds since the 17th of March. We're now transitioning into a bi-weekly phase because this is a lot of work, and each week, especially my colleagues were adjusting these survey questions to get more information about, for instance, the willingness of using an app to track contacts and so on. So a lot of information was really asked in a timely way, and other information was really asked as a kind of a stable background information for everyone. In the first round, we reached 550,000 people of the in total 11 million in Belgium. So that's not too bad. And nowadays we still are up in the 10,000s of participants. We see, of course, there is fatigue as such, but we hope that we can transfer this into a system which where we pose less questions, but the most relevant questions are kept, and then we can, we hope we can maintain a high level of participation. So there are different aims here, and these aims adjust while we go along. We want to assess public adherence to quarantine measures, monitor symptoms, investigate mental health, public opinions about certain quarantine measures, crowdsourced contact tracing, and so on and so on. And what I'm going to show is just very simple but insightful results actually from a survey like this. So this is one of the results, some selected results here, where we actually see three curves here with the dates on the x-axis, and then a density plot on the y-axis. And what you see is actually the moment that people had a last physical contact. And then you see that 65 years and older already reduced contacts before the lockdown was initiated. And then 18 to 65 really reduced it once the lockdown was in place. And then actually 0 to 17 years old people were the last ones to actually change their behavior in terms of this specific question, which is of course a proxy for that type of behavior as such. We also, in rounds 8 and 9, when we had more infections, we also asked people to report what is the likely situation where you got this infection from. And then we saw at that time, we saw a lot of people getting or being infected in the health sector itself. And I think that's very similar in other countries. Similar features have been obtained. I'm not going to talk too much in detail about these different results. Again, it's just to give you a flavor. And then also we ask questions like, to what extent do you think most households will stick to the same 4 visitors? So with this rule of 4, and what you actually see is that it just changed with age, and very surprising maybe to some extent is that a lot of Belgians actually obey the rule of 4, but at the same time they don't trust their fellow citizens to do the same. So there seems to be quite a perception that's ongoing. We've also used symptom incidence that was collected partly because of this large corona study to link the symptom incidence on March 24 to March 31 with the official data on confirmed cases. And the confirmed cases at that time were really cases that were hospitalized. And so that was very late in the disease process as such. And we were actually hoping with these symptom data that we could come up with a more timely indicator of the evolution of the epidemic as such. There are some technical details about the methodology used, and this is indeed a spatial model that we've used for this. Thomas Nijens has been the lead author on this. And what you see, and this is of course just a visualization at one specific point in time of relative risks. But it led to improvement in terms of the relative risks that we could assess as such. So yes, these type of data, these symptom onset data as such, they're very useful to monitor the spread as such. The only question is, of course, which symptoms are you going to play with? Because there is quite some diversity in terms of symptoms for COVID-19. And assuming that there is nothing else circulating in terms of respiratory infections, except maybe for allergies and so on, then we actually can interpret this as being indicative in terms of COVID-19 transmission. And the hotspot on the right-hand side, so northeast of Belgium, that's actually a city, for instance, where we saw a huge introduction, but also sustained transmission, and actually hospitals at that specific region could not cope at a certain point with patients coming in. And that was actually the only setting in Belgium where we reached maximum capacity as such. And the main reason is not only people coming back from Northern Italy or from Austria after the holidays, but also because they, at that specific moment in time when people returned, they also had 3 mass events where it is known that actually super spreading occurred. Very briefly on Socrates. Socrates is an online tool that we've constructed, leveraging social contact data that we've been collecting as part of the ERC grant that I have. And this is mainly work that initially has been done by Tang Van Wang and Pietro Coletti. And Lander Willem has made this into an easy package to use. It's online, you can experiment with that. And I think this is also a shout out to people collecting social contact data, that we're happy to help you sharing it through the platform socialcontactdata.org. There's a lot of material on there. Of course, everything can improve, so we're happy to get input there. But the main idea of this Socrates tool was really, and this is just a screenshot, but it's to look at contact data to come up with mixing matrices where you can actually implement age breaks, where you can look at the type of day, contact duration, contact intensity, and so on. And you can also look at age-specific transmission, where you can play with susceptibility of children versus adults, of course, also in terms of not only susceptibility, also infectiousness. And then if you go to a distancing tab, you can go to play with social distancing measures. And there is a paper behind this describing what the assumptions are, because there are, of course, a few assumptions underneath. But I hope that people find this really handy. And we're always welcome. We're always welcoming feedback on the tool, and as well as definitely also if you see some inconsistencies. We hope we have actually solved all of that, but it's not so easy to get the rich data sets like these completely errorless, I would say, without any mistakes in them. So feedback is always very welcome. You see an idea of what we've done here based on next generation principles. You can look at how contact patterns change and what the effect is of certain intervention measures. So it's a bit small maybe, but the R-naught ratio can be calculated. And the R-naught ratio is actually nothing more than the eigenvalue of the next generation matrix, assuming a certain condition divided by the eigenvalue of the matrix, assuming pre-pandemic contact patterns. Of course, you can play with this and you can download the data and you can do whatever you like in different ways. And if you feel like contributing with other comparisons, feel free to reach out. We're definitely open to work together on this so that this tool is useful for everyone. We're also working on this COMIX study where we look at these contact patterns and how they changed through time. So in Belgium, we looked at the social contact patterns starting during the lockdown. And then every 2 weeks from there, at this moment, it's foreseen that we do 8 collections every 2 weeks. So we still have 5 collections to go, but we're already looking out for additional funding to get more waves, and especially also when we think about the second wave. Yeah, then I think it's really good to have more data on this. And just to give you an idea of what this all means, is we looked at contact patterns during peacetime here. This is contact survey data on the right-hand side, on the top right-hand side, for Belgium from a survey in 2010, which is very much comparable to the Polymod survey from 2006. And we already investigated whether these two contact surveys are in line with each other. And you can actually assume, based on this comparison, that contact data are relatively stable over a short time period, being 5 years here as such. So if we take a small leap of faith, then we could actually look at Belgium 2020 being close to, or assume Belgium 2020 being close to Belgium 2010 in terms of results. And then we can look at the difference between the co-mix wave 1 on the left-hand side here, 2 and 3. And first of all, what you see here is not a complete matrix anymore, because we've been working with questioning panels, and panels are by default in Belgium 18 years and older. And we're trying to come up now with a second survey to actually get also information from children, although we believe that it's a little bit easier to do that through the adults themselves, so we'll be working on that. But for now, we only collected data from adults, and what you clearly see is that people adjusted their behavior tremendously during the lockdown period, so wave 1. Wave 2 was actually after phase 1A, so the business to business, and also there you don't see a huge difference as such compared to wave 1. And then for wave 3, you do see a difference, and that's after schools reopened, at least the initial phase of schools reopening, so phase 2. And one way to express that is to look at the ratio of the reproduction numbers again. And when you do that, then you can actually see how it displays in terms of transmission. Before I get to that, you see logical results, I would say, or intuitive results when you look at the home situation, where of course there are still quite a few contacts at home, although there are less so, and especially children and adults and grandparents, you see fewer contacts there. At work, you see a huge reduction, but you also see an increase again over the different waves. Travel had been reduced to about 0. And so we were very curious for the results this week, because we expect an increase again. And then when you look at the relative R naught, and this is based on something we've done in 2009 as well, but others have done this too, is to look at this R naught ratio. And then when you bootstrap these data, then you come up with ratios of R naught, or in other words, these ratios give you an idea of how transmission potential has reduced because of changes in contact behavior. Of course, there are limitations to these studies as well, because we do not take into account that people take precautions now. They wear masks, they keep their distance from others and so on, while still having conversations. So if we look at physical and non-physical contacts, as you can see on the top panel, it's conversational contacts. On the bottom panel, it's physical contacts. You do see some differences, and especially that physical contacts are still quite much reduced, and conversational contacts have increased quite a bit. We haven't put these data completely to the test in terms of disease transmission after loosening up, after these exit strategies, but the data do comply with the modeling that we've done during the lockdown and in these initial phases. So I think we're at the phase that we really want to integrate this much better into the modeling we've done. So I talked about these limitations. I do have to indicate that these R naught ratios are based on adults only, which is a limitation. So we're looking at different ways of actually making the square complete, and so that we can also look at the impact of children going back to school based on the recommendations made in these different phases of the exit strategy. In terms of serological surveys, I can tell a lot more, but I would like to just go to the main results, although the context is quite important. So let me be very brief about the context. The context is really that we're doing residual samples, and we're limiting those samples to persons who are not being tested for COVID-19. So residual samples means that you're looking at laboratory samples for other reasons than COVID-19 pathology. There is a disadvantage, because it could be that you are likely looking at a more vulnerable population, a more frail population as such. But at the same time, if you would compare to blood donors and getting samples from blood donors has a few disadvantages. Amongst them, the fact that blood donors are typically more healthy individuals, because they they're only allowed to give blood when they didn't have any symptoms or no contacts with COVID-19 cases in 2 weeks prior to the sample to the donation as such. And then the second thing is that blood donors are also only from the age of 18 plus and not younger than 18 years of age, and the residual samples are available for children as well, although especially during the lockdown period, we had few children that we observed. And now more and more samples from children come in. And what we actually see is an increase in seroprevalence from just a little bit before the lockdown, well, a few weeks before the lockdown, from about 3% to 6%, and then during the lockdown from 6% to about 7%. And it's very interesting to see this age profile, which is panel B on this graph, where you see that children are quite high up, even at the beginning already. And we believe that is likely due to families going on a holiday together, being infected in these holiday regions, coming back, and then children getting the infection within the household. And after that, of course, the infection, the number of infected children actually did not increase that much anymore during lockdown, simply because in the lockdown, all children, schools were closed, and children, for the majority, stayed at home. Of course, there is huge uncertainty related to this. And our main drive is actually here to really get a signal through time as well. So we have another data collection taking place in 1 week time, and then another one in an additional 3 weeks from there. So we hope we can actually picture the buildup of at least part of that immunity in the population, because we know the story on serology is not as clear as we wanted it to be. We calculated zero incidence and so on, but again, we have to take that with a grain of salt and be very careful about the interpretation as such. And then, of course, there is also the issue about sensitivity and specificity. We haven't, so there is a manuscript which is about to be submitted, basically, and we haven't touched upon that. We mentioned the sensitivity and specificity, but in the modeling work, we are taking this into account. So what are the type of mathematical models that we used for COVID-19? And I think this is also quite interesting, at least to me, and I'll give a kind of my own feeling about this, but I'm happy to hear other people's opinion. So we started off with using a meta-population model, and that's some work that we've done in the past together with Vittoria Colizza. A meta-population model which we developed for Belgium, which we used to look at influenza. We adapted that to COVID-19. And it was very clear already from the start that it's not so easy to play with that meta-population model. We had to adapt quite a few things. We had to re-evaluate how we've done things and so on. Also because we were simultaneously, and that in hindsight maybe was a bad idea, but we were simultaneously comparing France and Belgium in terms of the fitting and the work on the meta-population model. But Belgium is a very small country, and so you don't have to do the amount of detail that you have to put in for Belgium is different as the amount of detail you have to put into France. And some of that actually made the story quite difficult. And maybe in hindsight, we should have gone for a meta-population model for Belgium first, and then translated that to the French setting. But also at a certain point, Vittoria decided not to do a meta-population model for France anymore, but to focus on a stochastic compartmental model, especially for specific regions. And that was really a feeling about the meta-population model doesn't do the trick for COVID-19. Not completely. And the question there is that related to the fact that we do not capture super spreading events completely? the fact that it's kind of difficult with this kind of modeling approach to look at the impact of a lockdown, which is quite severe in terms of the contacts that people have. Whereas a metapopulation model, assuming an SEIR type of model with, well, a stochastic SEIR type of model, still does assume some random mixing in a population, or at least in the municipalities, if we look at the Belgian metapopulation model, which is not completely consistent with the implementation of a lockdown. So eventually we went to an individual-based model, STRIDE. STRIDE is a model that we've been developing for influenza, for measles. We were also ready to make a shift towards respiratory syncytial virus. And now we've actually stopped that for a moment, and we went to look at COVID-19. And for those people who are interested in the other models, I'm not going to go into detail here, but everything is there in terms of information, and the manuscripts will, because we've been lagging behind in terms of getting manuscripts out, simply also because of my role in informing the government. We didn't have time to do the write-up as at the same time as informing them. Although we had some internal review in the EpiPose project. But the assumptions are here. It's not all in detail, but the manuscripts should be out this week or next week in terms of preprints. And then we're of course very happy to get this further validated. What I wanted to focus on because I also want to leave some time for questions, is to have a look at this individual-based model. And what I think is particularly nice to see, and also other studies are coming out with these ideas, is, well, we had a base case scenario where we made some assumptions. And in terms of contact patterns, that was quite similar to what the COMIC study revealed. But we also were able to implement contact tracing with different assumptions. Here are the assumptions that we used before. Now, nowadays, some of these assumptions have changed, also because the testing and tracing strategy has changed. And just to give you an idea, transmission dynamics are consistent with what has been published. But this is kind of the model fitting that has occurred initially, and which is still valid today. We're a little bit high in the model in terms of prevalence, I would say. So we're readjusting that a little bit, calibrating that more to this final zero survey that we found. But you could actually look at different exit strategies, and you could try to mimic what happens in terms of having a second peak. And then you see that there are plausible scenarios in which you would expect a second peak in summer. But with testing, tracking and tracing, you can actually lower these in terms of the burden, in terms of hospital admissions. And well, we've done more scenarios, and we think we're actually following more of the scenarios which are at the bottom, and that's of course what we hope. Although with this last phase, we are not completely sure whether we will have a quieter summer, let's say, and then we will have a second peak starting, well, in October, November, I would say. And of course, the September reopening of schools and so on could actually cause this second peak to occur. We also looked at household bubbles and how to integrate that, playing with frequency and so on, because not only because of this rule of 4, but now there is this certain rule of 10. So you allow people to meet up with more people, but you limit that in terms of frequency during the week. And we see that people have, of course, there is the perception of people that they can now do whatever they like. But most people still obey these rules very much, and they meet up with people outside rather than inside. And that could be a very important role, because we haven't looked at seasonality within this in this setting. This is again just a visualization. This should be updated again as well. But you see that for the baseline scenario, where you can meet up with people randomly versus household bubbles, you actually see a reduction in this potential second peak in these different scenarios. The visualization is different here. And what we also assumed, or what we played with and tested, is if you meet up with another household, to make sure that you're not crossing generations too much. So intergenerational mixing is limited, and that has quite a big impact on the burden, especially in terms of hospitalizations and in terms of mortality. We can look at effective reproduction numbers and so on in different situations. I'm not going to go into detail as such. This is already looking quite far in the future, if you ask me. And of course, we should further validate this. But the model is also being used to inform people on who to test and when to test people in terms of contact tracing, how many tracers should be working on this. For Belgium, we had 2,000 tracers in mind, but they don't have a lot of work at this moment. So whereas the politicians want to reduce the number of contact tracers, we want to be very careful. So there's, as always, this different perspective on the matter. So I'm going to keep it limited there. I do hope that I've been able to give you an idea of what we've been doing and how this has helped. It helped guiding the exit strategies. It was definitely not the only thing that people relied on. I think that shouldn't be the case. And it was an advice to the government. And of course, it's the prerogative of the government that they have to make decisions. And I think it's fair to say that communication was not always optimal. So we also saw that in the large corona study, that trust in the government has diminished over time. There was a lot of trust in scientists. We also see that there is a tension because a lot of people are saying now politicians should be back in charge, whereas virologists and so on shouldn't be. But Belgium is a country of 11.5 million people, where I think nowadays we have about 11.5 million virologists. So it's kind of a difficult setting. So we didn't have a tradition that science could be so powerful in decision-making. I think during this crisis, this has been successful, and we hope actually that we can actually contribute to getting ready for the second wave, because that's really essential. And to end, I'm going to show this picture again. This is actually a picture made by a friend of mine who's an artist on the coronavirus with the Tinker together with a mouth mask as such. And he's actually selling them. So if you want them, it could support artists in these difficult times. Thank you all.